Well, thank you for coming and being with us. We're going to get started, and Piyush will start by introducing himself and CareFirst.
Morning, everyone. My name is Piyush Khanna. I'm the VP of Clinical Services at CareFirst. CareFirst is a not-for-profit health insurer. We are serving about 3.5 million members in the Maryland area, Northern Virginia, and the DC area. I've been with CareFirst for nearly a year, and excited to be here.
Awesome, thank you, Piyush. So I'm Mo Eitenauer. I'm the Chief Product Officer at MRO Corporation. MRO is a 3,000 member organization that works with payers, providers, patients to exchange clinical data. So we were founded over 20 years ago with the express goal to help providers manage all the clinical data requests that they get. So whether it's continuity of care from other physicians, from payers like CareFirst, from patients, legal, you name it, anything that anybody who wants a record, we would help them. We have since got many accolades, so we are a DAV certified data stream, which enables payers to not have to do primary source verification, and I'll be talking about that in a little bit. So we're here to talk about our partnership with CareFirst, but I want to first start with talking about what the challenge that CareFirst was experiencing that could kind of illuminate the kind of work that we do together. So if you've worked in healthcare for a long time, you know that healthcare is very, very complex. One of the biggest challenges that we were seeing is that providers are just inundated with many needs for clinical data. Both the providers and the payers have to exchange data, and there's value-based payments, there's quality measurement, there's claim adjudication, there's care management, all requiring clinical data in order to base the decisions there. And then in addition, this is a pretty resource-intensive endeavor, as you can imagine. So there's, each payer often has different standards. They'll ask for a fire resource for one program, and then a CCDA for another program, and a PDF for another program. So you can just think of the complexity that providers have to incur, and also on the payer side as well. There's a big burden to be able to aggregate all the data coming in. We actually took a look. There was a study last year that was done in JAMA about how much impact providers bear by the demands of doing quality measurement, whether that's for CMS or for private payers. And when we extrapolated those findings, each provider basically spends 17,000 person hours just on quality reporting. And as you know, healthcare providers are working on very thin margins. In the same way, payers also work on pretty thin margins. But all these demands are really compounding the impact that providers have to bear. And then lastly, you can think about it, things like compliance. You think about changing data standards. You think about PHI, making sure that the right data ends up in the right hands. So now, enter the relationship we have with CareFirst. So we've been on this journey with CareFirst since 2019. The idea, CareFirst actually had a pretty forward-looking idea. They wanted to connect with the entire provider network and see the lives of every single member in their network and be able to manage them. At the time, believe it or not, it was a pretty revolutionary idea, and they actually were ready to do it. And so we've been on this journey for the last few years, and to date, out of CareFirst's 3.5 million members, we've been able to connect 1.2 million, which it seems like it's only a portion. The thing that's beautiful about this relationship is that we connected them to the most difficult EHRs. So if you think about specialist EHRs, you think about individual ambulatory EHRs, those tend to be, especially the legacy ones, the most difficult to connect. So the idea that we've been able to connect about a third of the membership is a pretty big accomplishment. And then as you can think about it, so CareFirst is able to see all these visits that are coming through. And to date, we've been able to connect over 3,000 of their members, of their providers in their network, and we keep adding more and more. The other piece here, you can see in the middle there on data standardization. As I mentioned, we are a DAV validated data stream, which enables for certain cohorts of providers and specialties for us to be able to have CareFirst not have to go through primary source verification, which can be a pretty burdensome endeavor both for the provider and the payer. The use cases, now that we've connected so many networks, we're able to support a lot of different use cases. So we've been able to retrieve over 2,000 records for CareFirst, ACA, and Medicare Advantage risk adjustment. And CareFirst is one of the leaders in the DMV area as far as their risk adjustment program for ACA. And then secondly, over 4 million cumulative records that we've been able to submit for HEDIS and other quality programs. So what this helps CareFirst do, and Piyush is going to talk a little bit more about this, is it obviates the need to do continuous chart chasing. We're in the business of helping providers exchange data, and we know how burdensome and how wasteful chart chasing can feel. And so the fact that we have all of this data aggregated and normalized enables CareFirst to be able to avoid those costs. And in addition, we've actually also been able to create a longitudinal record out of this data that enables CareFirst to see the members across the care settings that they've been seen throughout their care journey. So that's just an overview of the program. Piyush will talk a little bit about the impact that we've been seeing to date. Go ahead.
Thanks, Mo. As Mo talked about, the challenge that we started off with was that we had a fragmented ecosystem where we had to go to multiple providers to look for information. As you know, HEDIS Quality Stars is a very important part for revenue generation for us, as well as we were doing chart chasing, which would take us sometimes months to figure out who do we need to go to. There were several layers of vendors that we had to work with before we could get the provider data out. So we've been able to get some significant results with this clinical data exchange platform that we have. We recently, last year, got another half star point added, which we attribute to being able to turn around these charts in a more timely manner. We had risk adjustment also, right? I mean, Mo talked about, we were chasing a lot of charts all the time, and as we look at more prospective ways to look at risk adjustment, that's an area where we've also seen significant savings. Things that would take us months, now we can do it in a matter of days, right? Think of the operational SLA. Now again, we have only 30% of our population today coming through this data exchange platform. But as we are adding more and more members and are getting more and more providers connected, we are able to leverage this platform and really reduce the time that it took for us to be able to access that information. Also, as Mo talked about, we are able to extract CCDA data, which then we can feed into downstream systems within the CareFirst ecosystem as well. Not just look for chart chasing, but look at downstream applications as well. And I'll talk a little bit about that too. Again, you know, we are very focused on the provider side as well. Providers have had to give us access to direct EHRs, have had multiple phone calls from multiple parts of the organization, right? Legal wants this information, behavioral health team wants this information, care management needs this, prior auth needs, lots of departments within CareFirst looking for information. And the providers are fielding all these conversations. So they were able to say, well, here we have connected one pipe out of our EHR with the data sets that you have, and then you can extract that information and have access to that without getting the provider to actually be involved in that process. So that's been a huge help for us. The longitudinal record that Mo talked about is something that we've been trying to create, right? A typical member has 6 to 7 providers that they're working with. Think about 6 to 7 EHRs that this data is hitting. Can we collect that information and put it into a single longitudinal record? That is also very important for us. Again, not getting getting ADT information, getting clinical data in drips. We are able to see it all the way through a 360-degree view of the member's clinical data set from these providers. So that is also, again, very, very helpful for us. Again, we talked about the DAV. Getting good, curated quality data is very important for us. Trusting that information, making sure the A1C levels and the GFR values coming from these EHRs is very important. I can't emphasize that enough. Having good curated quality data is very important. So our partnership with MROs really helped us in that regard as well, where at the source we are able to put a catalog of data rules and quality checks in place, so we trust the data as it goes through our claims adjudication platforms or goes through our quality engines. So that's also something that we've been able to achieve for the population that sits within the MRO repository. Again, as we are on a journey, we started in 2019, just beginning, there is lots of opportunities for us to be able to take this data further, right? We think about our care management ecosystem. We believe within our care management, we want to get this information at the point of care. Our clinical teams have to spend a lot of time hunting and looking for this information, getting information from different sources, not just claims and counter data, but also looking at other opportunities as well at the point of care. We've just started an HPPC program. Having access to advanced directive, for example, sitting in an EHR somewhere would be very, very helpful in creating a care plan that is meaningful, that the members already told us. So just as an example of getting that data that is locked up in these EHRs and actually getting it to the care management staff at the point of care. We also believe we want to start doing network modeling. As you know, value-based care, you just heard about it. Value-based care is very important for us. We are writing contracts with the providers all the time. Can we do better network modeling and understanding the usage of our patterns, right? We put all kinds of KPIs, admission rates, readmission scores, and ED visits. Also want to put stuff like patient leakage, where a member might have gone out of the integrated network that the provider has set up. So looking at ways in which we can leverage this data in the future around network modeling, network adequacy as well. Closing the gaps of care, we have already been talking about taking data out of the EHR. Imagine a world where we can actually have a bidirectional interface going, where we are able to feed the information back to the provider as well for the information that we are able to collect. Could we close gaps in care much more easily? There is a lot of incentive programs that we have with the provider community. They would really like to know if they can get that incentive payments and dollars, again, creating gaps of care. We have talked about prior authorization as a burden, that lots of opportunity exists in us being able to do maybe prior auth submissions in the future through an EHR. And again, collecting clinical data on the payload for a EHR submitted prior auth coming back into a CareFirst ecosystem, and then the results going back. Data is the new currency, as we all talk about it, right? There's lots of other dimensions besides the clinical data that we want to be able to connect, right? If I know that a member is going to get discharged and they don't have transportation after a hip replacement, wouldn't it be great to be able to look at providing Uber for them to be able to go home? If I know they're diabetic from the clinical data, wouldn't it be great to be able to send them meals, because after a hip replacement, they're not cooking, they live alone. There's lots of areas and use cases that we are exploring to be able to look at this information and data and provide further frictionless experience for our members as well as provider community. And that is something that we're excited about as we go forward as well.
All right, so I'm sure you all have many, many questions. That's the prepared remarks, but we're open to having a conversation. Any questions you have about the partnership, how we work together, that could help inform your own journey. So any questions?
I think we did a great job.
Any? Yes? Yes, so we have, actually CareFirst calculates the gaps. So they get the gaps, and then MRO is we're going to be connecting either through CDS hooks or other ways into the various EHRs. Because we connect with over 44 different EHRs, as we all know in healthcare, like everybody likes to say, oh, we're doing it in FHIR, it's a standardized model, but when you're talking about the smaller EHRs, oftentimes they actually aren't really using technology that you can connect to easily. So it's probably going to be a hodgepodge of different ways of connecting, but that's something that's on my roadmap for this year to push the care gaps to the point of care. And documentation gaps too will be coming down the path.
I think there are opportunities for us in particular. Today we submit that information The providers have to come to us, their portals, they have to download Excel sheets that they're managing, which is not a very productive way from our perspective. We have clinical staff who are interacting with members. I want them to have access to gaps in care as we are touching these members. So there's opportunities today, but getting that information back through a CDS hook or a Smart on Fire app within the workflow of the provider, I think is the approach that we would like, instead of a sidebar conversation, oh, the member was here, the patient was in the office and they walked out, and then we are collecting that data today after the fact. So I think there's some use cases and opportunities through the partnership. We've already connected that into that EHR. Now can we do a bidirectional and push information into the EHR itself?
Yeah. And I'll just say one thing, I see that you're from Athena Health, that one thing that we would like to work with the EHR companies on is to help streamline the number of apps and pop-ups that providers see and make it, so we can talk after this, make it much more seamless. No doctor wants a bunch of pop-ups while they're trying to just get their work done, so we want to make sure that that's an easier experience. Any other questions? Anybody else? Yes. Mark just asked some of the challenges we had getting to this place. So one of the things that I like to say about trying to connect a payer to their network is it is seldom a technology problem. The connections, getting a technical connectivity, that's not the problem. The biggest challenge was getting the minds and the time of the provider and them willing to get the connectivity that was being sought. So all of those contracts, all of those conversations with providers are the things that are taking longer than even the technical connectivity. The technical connectivity is pretty easy. It's the contracts, it's the security assessments, it's all these other ancillary things that need to be done to connect providers. Anything else?
No, I think you summarized it well, right? It's more of a change management aspect, and there's a lot of inertia, and so working around that, making sure the providers are comfortable, getting legal documentation, contractual. There's a lot of aspects over and above just the technical. I think the technical implementation is the smallest component, but getting the contracts in place, making sure that the data that we need is also accessible, getting those connectivity done is sort of, I think, the largest challenge we faced so far.
Yeah, and I'll just say one last thing is that having bidirectional exchange is so important for the providers because, you know, we at MRO, we've been working with providers for years. Providers feel like people just want to take from them. Like, give me data, give me data, give me data, and they get nothing in return. And so that's why it's important to have both. I'm happy that you know, things like TEFCA are looking at payer to provider bidirectional exchange because that's an important aspect of this. Providers have to feel like they're getting value out of the relationship as well and not have it just be you know, data leaving their premises. All right, any other questions? I can cold call people too. Sean? Sure. Yes. Yeah, it was a little bit of the question. The question was, why did we choose to start with the more difficult EHRs to connect with first? Than the bigger ones. It's a pretty complicated reason. It's one, typically the ambulatory EHR providers are like single shingle Dr. Mo's, so it's much easier to contract and negotiate with those providers than big health systems like Johns Hopkins. I don't know how long it took us to negotiate with Johns Hopkins. It took a while, though their technical integration is pretty easy because it's just, you know, Epic and caboodle, you get the app, it's pretty easy. So that's one of the reasons. The other piece is that MRO, I don't know if folks know, we also have a clinical registry business that specializes in specialties. So if you think urology, cardiology. So we already had the expertise on how to connect with some of these smaller EHRs that didn't have the technology yet. And remember, this was before FHIR. We have been at this before there were these standards, there was this technology. So oftentimes I like to think that we were meeting the providers where they were, because most of them are on EHRs that were not enabling bidirectional exchange or any other kind of exchange. Does that help?
I think another factor for us, another dimension was, as we were writing value-based contracts, so I made sure that as the contracts were coming up, we were adding this language into that value-based contract, because the KPIs are the data is of interest to us to better measure how the contracts are progressing. Are we getting the outcomes that we were after? So as the contracts came up, we just had our 3 largest health systems sign up, and they are going live this year. We've been negotiating with them for a year nearly before we got the final contract. But that's been another approach we have taken, is as the contract's getting opened up, let's make sure that this becomes part of that negotiation.
Yeah. Yes, sir.
We made a decision a while back that we were not going to get into the business of connecting with 44 different EHRs. That was not something we were going to take on. We were looking for a partner that could be that aggregator of that data information. And so we started working with MRO as of 4 years ago, just to look at, because as you know, I know MRO makes it sound simple, but it's not always that easy to actually get that data, right? Versions of software also continuously evolving, push, pull, fire, and there are different levels of sophistication within the IT teams, within the provider groups as well. So we have done some integration directly, but we decided a while back that we were not going to do that point-to-point integration. There are some opportunities, I think, with TEFCA and others that, QHIN's coming in. We're looking at and evaluating some of those parts of the puzzle as well to see if, but we believe there'll always be a middleware instead of a direct connection into the EHR.
Yeah, and I mean, oftentimes when you have, health plans like regional plans like CareFirst or even smaller plans, they typically don't have the resources to expend to build their own connections with hundreds of providers in their network, and that's the place that a company like MRO, we come in. But today we support folks that are doing chart chases, and then we see the delta with what we've been able to do with CareFirst. It's a pretty impressive ROI that we've been able to achieve, because there's, payers typically have to pay a chart chase company, pay a release of information company like us, have their own staff, and then have additional vendors just to standardize the data, standardize it for their coding platform. I mean, there's just so many different steps that payers have to do, and we've completely eliminated that entire world, and they're able to access the data directly through our platform. So,
it's tens of millions of dollars being spent today in the ecosystem that is not on MRO, right? Think about the 30% that we have, 70% that we are having to force to multiple vendors, multiple departments. Sometimes we are paying different vendors for the same data set. How do we not have those conversations? We are going to publish, because of the interoperability, we're going to have a FHIR API, we will have CCD consumption. So that's sort of become a standard for us, right? How do we take data from MRO? We want to build certain pipes. And if an EHR wants to send us information, we'll still be using that standard interface. But we're not going to get into the point-to-point integration business.
Great. Any other questions? Well, that's all we have. You can visit us. We're right behind you over there, where our booth is booth 2436. So happy to take questions there. If you're a little shy, we can have a one-on-one conversation. So thank you so much for the time.
Thank you all.